This video, we will be discussing MCQs related to developmental disturbances and odontogenic tumors and cysts. Our first out is dentigerous cyst is associated with, and your options are A. Impacted third molar, B. Impacted supernumerary tooth, C. Odontome, D. All of the above. The correct answer here in the given situation will be impacted third molar. So remember, as a rule of thumb, dentigerous cyst is always associated with a crown of an impacted, embedded or an unerupted tooth. The most common site will be mandibular third molar, followed by maxillary third molars and maxillary cuspids. Now, the most common supernumerary tooth is your mesiodens, and it's rarely associated with mesiodens, so we rule out option B. Option C says odontome. The most common cyst associated with odontome is COC. In 24% of odontomes are associated with calcifying odontogenic cysts. Now, moving on to question number 2. A patient wants replacement of his extracted mandibular first molar. Dentist takes an IOPA and accidentally found adjacent premolar's root was rounded and blunted at the apex. Periodontal ligament was intact with lamina dura. The diagnosis is, and your options are option A, cemental tear, option B, hypercementosis, option C, dilaceration, and option D, cementoma. The correct answer here is option B, hypercementosis. Now, the moment you look at the options, we know option A and D, cemental tear and C, dilaceration are immediately ruled out. So it is between cementoma and hypercementosis. So let's understand why we've gone with hypercementosis. If we know hypercementosis is simply cemental hyperplasia. So it is a non-neoplastic condition in which excess cementum is deposited, cellular cementum, in continuation with radicular tendon. Whereas your cementoma or cementoblastoma is an odontogenic tumor with proliferation of cementoblasts that result in formation of a large mass of cementum or cementum-like tissue on the tooth root. Now, both of them on the radiograph will appear as radio-opaque masses. However, now your cementoblastoma is a tumor. So it will result in obliteration of PDL space. Whereas your hypercementosis, a most common site of hypercementosis is usually apex of the tooth, resulting in rounding of the tooth root. The tooth will, the root tip loses its classic spike appearance as mentioned in the question. And there is normal periodontal space. So that's why we've gone for your hypercementosis. Now, question number 3 is, a 4-year-old child has normal complement of primary teeth, but they are gray and exhibit extensive occlusal and incisal wear. Radiographic examination indicates extensive deposits of secondary dentin in these teeth. The most likely diagnosis is, and your options are option A, neonatal hypoplasia, option B, Amelogenesis imperfecta, option C, cleidocranial dysplasia, and option D, Dentinogenesis imperfecta. The correct answer here is option D, Dentinogenesis imperfecta. That is a genetic defect resulting in defective formation of dentin, which is characterized by gray to yellowish brown teeth. Both deciduous and permanent dentition are equally affected. The crowns are bulbous in appearance. They have extremely, excessive formation of irregular dentinal tubules with areas of uncalcified matrix, resulting in complete obliteration of pulp chambers and root canals. Now, why we did not go for neonatal hyperplasia? Neonatal hyperplasia usually affects deciduous teeth, and it is characterized by hypocalcification. Dentinogenesis imperfecta will result in a pitted, discolored, appearance of the teeth, where the enamel quickly wears off. So that's why we've gone for dentinogenesis imperfecta. Fourth question is, multiple periapical radiolucencies are seen in, and your options are option A, jaw cyst basal nevus syndrome, odontogenic cyst, C, cherubism, D, thyroid disorders. The correct answer here is jaw cyst basal cell nevus syndrome. So if you remember, your odontogenic cyst has a unilocular radiolucency with a well-defined peripheral rim. Now, Jaw-cyst basal cell nevus syndrome or Golden-Gault syndrome is characterized by multiple OKCs resulting in multiple radiolucencies. Cherubism will also show bilateral multilocular cystic expansion of jaw, and it shows a floating tooth appearance because of extensive destruction of alveolar bone. Then moving on to fifth question, pepper and salt appearance and radiographic description of which of the following lesion? Your answers are option A, calcifying epithelial odontogenic tumor, option B, ameloblastoma, option C, calcifying odontogenic cyst, and option D, follicular cyst. So the correct answer here is option A, CEOT. So if you remember, calcifying epithelial odontogenic cyst will show a diffuse or well-circumscribed radiolucency, and you see a combined pattern of radiolucency and radioopacity. That means pepper and salt with many small irregular bony trabeculae traversing the radiolucent area in many directions, producing a honeycomb pattern. And these scattered flecks of radioopacity throughout the radiolucency also give a driven snow appearance or a salt and pepper appearance. Now, ameloblastoma shows a multilocular radiolucency. Your calcifying odontogenic cyst will show radiolucencies or radiolucencies with foci of opacification, which is usually your odontome. Follicular cyst is dentigenesis, which shows a radiolucency associated with an impacted tooth. Now, the next question is polydactyly, that is multiple digits or fusion of digits, craniosynostosis, late closure of fontanelles are feature of, and your options are A, Apert syndrome, B, Cruzen syndrome, C, Piri-Robin syndrome, and D, Down syndrome. The correct answer here is option A, Apert syndrome. It is also known as acrocephalosyndactyly. So as the name is suggesting, that there is the craniosynostosis, that is premature fusion of cranial bones resulting in abnormal skull shape. Polydactyly and syndactyly, that is varied number of finger and toes are fused together resulting in sock feet and mitten hands. And we also see a late closure of fontanelles along with the gaping midline defects. So the correct answer here is your Apert syndrome. Now, Cruzen syndrome is characterized by craniosynostosis, midfacial hypoplasia, and hydrocephalus. Your Piri-Robin syndrome is characterized by micrognathia, glossoptosis, and upper airway obstruction. Down syndrome is trisomy of 21 with multiple skeletal intellectual anomalies. Now, the seventh question is, a 15-year-old boy shows an inverted pear-shaped radiolucency between upper central incisors. The teeth are normal in all aspects. The most likely diagnosis is, and your options are option A, globulomaxillary cyst, option B, nasopalatine cyst, option C, aneurysmal cyst, and option D, dentigenesis. The correct answer here is nasopalatine cyst. So, we'll obviously immediately rule out your aneurysmal and dentigenesis because of the site. Now, globulomaxillary cyst is a fissural cyst within the bone between your maxillary lateral incisor and canine teeth. So there's a pear-shaped radiolucency between the roots of lateral and canine. Now, nasopalatine cyst occurs there's a radiolucency in the midline of anterior maxilla. It's again a developmental cyst, and it occurs due to presence of epithelial remnants of nasopalatine ducts. So the other name for this is nasopalatine duct cyst, and because it's so close to incisive foramen, it's also known as incisive canal cyst. Question number 8 is Apert syndrome shows all the features except, and your options are tower skull, B, severe case of clover-like skull, C, pseudo-cleft formation, and brachycephaly. Out of the given options, the correct answer is going to be B, severe case of clover-like skull. So remember, Apert syndrome had three features. There was craniosynostosis, that is early fusion of cranial bones. Then there was syndactyly and polydactyly. And lastly, there was late closing of fontanelles with gaping midline defects. Now, all the features mentioned here are related to your craniosynostosis, that is early fusion of cranial bones. Now, the mildest manifestation of craniosynostosis is your brachycephaly. Brachycephaly is a wide skull with a flat occiput, as you can see in the diagram, and this happens due to premature closure of coronal sutures. These sutures here. Now, the other name for Apert syndrome is acrocephalosyndactyly. So, acro means a pointed skull. So, that's your option A, tower skull. As you can see in this diagram, this looks the pointy skull or the tower skull. Now, this is a more severe manifestation of craniosynostosis as compared to brachycephaly. Then, our third option, pseudo-cleft formation, we rule this out because the other features are maxillary hypoplasia, drooping angles of mouth, high arched palate. So, due to a high arched palate, we have pseudo-cleft formation or a bifid uvula, sometimes a proper cleft and V-shaped maxillary incisors. Now, your clover-like skull is actually a clover-shaped skull or a tri-lobed skull. This is the most severe and the rarest finding in Apert syndrome. There have been 3 cases in literature which have been documented. So that's why I'm saying out of the given options, we'll go for severe case of clover-like skull. Moving on to the 9th question, destructively invasive, locally malignant with rare metastasis. The lesion is, your options are option A, fibroma, option B, ameloblastoma, option C, papilloma, and option D, none of the above. The correct answer here is option B, ameloblastoma. Now, if you remember Robinson's definition of ameloblastoma, uniac, unicentric, non-functional, intermittent in growth, anatomically benign and clinically persistent. Now, even though ameloblastoma is slow growing, but it can be locally aggressive and has a high chance of recurring if it is not completely removed. That is why the term locally malignant is being used. And it is known to cause expansion of cortical plates and destruction of the bone. So it is definitely destructively invasive, and metastatic transformation is extremely rare. So we go for ameloblastoma. Your fibroma and papilloma are totally benign lesions. Now, our next question is also related to ameloblastoma. It's standard treatment. Our options are A, segmental resection with 1 centimeters of normal bone, en bloc resection, C, enucleation, D, enucleation with cauterization. The correct answer is option A, segmental resection with 1 centimeters of normal bone. Now, segmental resection means removing the tumor along with a part of normal tissue around it to prevent reoccurrence or reinfection. Option B, en bloc resection means removing the entire organ or tissue as a whole, which is done in cases of malignant tumors. Enucleation is used in terms of cyst, where the cyst is removed along with its content as a whole so that it comes out clean. And enucleation with cauterization means that after enucleation, you use chemicals or electricity to destroy parts of tissue, to kill any remnant tumor cells and to seal the blood vessels and stop bleeding. Now, our next question is difference between formation of nasoalveolar cyst and globulomaxillary cyst. So to understand this, let us look at your embryology diagrams from the formation of nose or nasal pits. So out here in yellow, we have our mandibular process, maxillary process in purple color, and this is your lateral nasal process in orange, and blue is the medial nasal process, and right in the center is the frontonasal process. What happens in normal formation is that your maxillary process will fuse both with medial nasal process and lateral nasal process, and both the nasal processes also fuse, and the frontonasal process becomes narrow in formation of nose. Now let us look at your cyst. So your nasoalveolar cyst, the other name of it is Klestadt cyst. It is a soft tissue cyst, and it is formed because of entrapped epithelium at the junction of the lateral nasal process and the maxillary process. So this here, let's mark it here in red. This is the site of your nasoalveolar cyst. It's a completely soft tissue cyst, and only sometimes radiographically a shadow is seen. Now, your globulomaxillary cyst, it is thought to have formed at it's a bone cyst, and it is formed due to failure of fusion of median nasal process and your maxillary process out here, and it's usually seen as a pear-shaped radiolucency between your lateral incisor and canine. However, latest reviews suggest that globulomaxillary cyst may not be a embryonic cyst. It may be a odontogenic cyst with maybe an LPC. So it is slightly there's a slight dichotomy about globulomaxillary cyst in the recent years.